Good morning, everyone. My name is Chemyeeka Tumblin, and I am a part of the City Match team. I am currently presenting from Nashville, Tennessee, where I am on the land of the Cherokee, Swanee, and the Yuchi. I want to say thank you and welcome to day 3. We hope that you all had an amazing time in the workshops, plenaries, and got to see some of the abstracts before you all joined us. This morning, we are going to do a mental health session talking about the mental health of our public health workforce, our communities, and of course, those who we serve. We know that for the past 2 years and still, you all have been juggling life, yourselves, as well as the work you do. So we're hoping that throughout this session, you all gain skills, knowledge, and take away resources to not only help you during this time, but also those around you. First up, I would like to introduce you all to Dr. Vinson. Dr. Sarah Vinson is a triple board certified child and adolescent, adult, and forensic psychiatrist, a proud alum of Florida A&M University for undergraduate. She graduated from the University of Florida College of Medicine as an inductee in the Chapman Humanisms Honor Society and with research honors. She then completed her general psychiatry training at Cambridge Health Alliance, Harvard Medical School. This was followed by fellowships in both child and adolescent and forensic psychiatry at Emory School of Medicine. She is an associate clinical professor of psychiatry and pediatrics at Morehouse School of Medicine, where she is the lead architect and is the program director for the Child Psychiatry Fellowship, the first and only at an HBCU medical school. She is also an adjunct faculty at Emory School of Medicine. Dr. Vinson is the co-editor of 2 texts, Social Injustice and Mental Health and Pediatric Mental Health for Primary Care Providers. She has written book chapters and peer-reviewed articles on the social determinants of children's mental health, child trauma, social media and children's mental health, fostering resilience, the criminalization of mental illness, and the school to prison pipeline. She has received multiple awards in recognition of her leadership and service, including the 2020 City of Atlanta 40 Under 40, the APA Sampson Minority Fellowship Alumna Award, the University of Florida Outstanding Young Alumna Award, and a NAMI Exemplary Psychiatrist Award. Dr. Vinson has been elected and/or appointed to the national and statewide office by her professional peers. She serves on the boards of the American Association of Community Psychiatry and of the Vinson Center for Mental Health Law. She has been an invited speaker at numerous events, including the American Psychiatric Association annual meeting, the National School-Based Health Conference, the National Urban League Conference, and the Congressional Black Caucus Health Brain Trust. Dr. Vinson was appointed by the Georgia governor to the 24-member Behavioral Health Reform and Innovation Commission and is the Child Subcommittee Chair. Dr. Vinson, we want to thank you here and welcome you and just tell you how grateful we are that you've joined us today, and we look forward to hearing what it is that you have to share.
Thank you so much. And thank you to everybody who was a part of this clearly just amazing and much needed conference. I'm so glad to join you all today. I am currently seated in Atlanta, Georgia. And that is where I'm presenting from. And this is from the land of the Muskogee Creek people. So we will get started. So this session as a whole is just 80 minutes. And I know that all of you are pulled many directions, and that may be even more so the case when you're virtually, and there may be all kinds of distractions either in your office or at home. And so you're at a branch point. Do you really do all you can to be 100% present here and kick back a bit? Or are you still trying to check emails and multitask and get everything done and be efficient? But I would encourage you to take use of this time to really reflect on your own mental well-being and to make a plan and to think about where you are now and where you want to be. And if you're in a good place, how you want to stay there. Your emails will be there. To-do lists are living documents. Multitasking is not a real thing. So give yourself, not the panelists, not the conference, not us, give yourself 80 minutes. And if you work a 40-hour work week, which I'm guessing most of you work more than that, it is 3.25% of your work week. So please, I ask you, really take this time for you. So we'll start by just asking what is mental health? And I do that because so often, whether it is public health or mental health or the healthcare system more generally, health is often defined in terms of disease and symptoms and diagnosis codes. It's less so about what is optimal, where we want to be, what is the ideal. And we don't spend nearly as much time talking about that, even when the title of something is mental health. For instance, the mental health care system, which we know is really much more focused on illness and sickness. There's this definition from the World Health Organization that I really like around mental health. It says a state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to her or his community. And what I would like to draw your attention to in that definition is that there is a way that it is very dependent on what is going on in family, in the larger environment, in the community in which people live. It's not this thing that's isolated, it's not individualistic, but it's very contextually driven. And that's really what mental health is about. And something that you think about, of course, as people in the public health field, but something that we often apply to other people and maybe don't apply it to as much to ourselves. So when we're thinking about mental health, mental illness, we know that it is a continuum. It is not this, you are mentally ill or you are not. You're mentally well or you are not. Everybody is on a continuum at any given point in their lives, and everybody can go up or down on this continuum depending on what's happening. And we know that there are protective factors, there are supports, there are adaptive coping that help push us more toward health, and that we can have risk factors and stressors and maladaptive coping that push us further away from health and to the other side of that continuum. And it may be that, you don't meet the threshold, or people that you're working with or talking to don't meet the threshold for a diagnosable DSM condition, but they could be operating in a way mentally that doesn't match that definition or that description from the World Health Organization that we just went through. And what we've seen over these past few years, and of course, we're not out of the woods yet, otherwise we'd all be in New Orleans eating beignets and oysters together, that we have seen those stressors go up, our coping cut short in terms of the options that are available to us, that support changing how it has to look. And so not surprisingly, we have seen as a whole, our community, our country is dealing with more symptoms of that compromised mental health. So as we're thinking through these issues as they pertain to public health professionals, to those we serve, of course, there's what's happening to the community as a whole because of COVID and all of the reactions and responses to it. But there are also other things that we carry with us, right, that are part of how we experience the world and part of how the world responds to us. And that could be our race, our culture, it could be our sexual identity, how we identify in terms of our gender. And there's also just the reality that this is something that has been going on for a while. This is not an acute stressor. It is an acute on chronic stressor at this point. And so we can't just have a discussion about this is what it's been like for this group of workers or this race of people or this category, but we all have these intersectional identities that are contributing to how we experience this and the stressors that are coming our way. And there's a way that because of the stress our society is under, we're seeing that polarization take place, and it may have differential effects on people depending on how they identify or even how the world identifies them. And so in that context, right, we are thinking about trauma and what that has meant for us, that basic sense of safety and security that has been undermined recently because of COVID and the practical threat that that has been to people's lives, to the lives of their loved ones who may be vulnerable, what that has meant on the world stage. We know that we have also had a I don't think we've had a racial reckoning yet, but there's been more discussion around those things because of recent events as well. Of course, we have Me Too, which has brought attention to the issue of women and their safety. And in this context, in family systems that are stressed, that don't have the support that they need with people stuck at home. There are also concerns about the impacts on children and on the generation that this has gone through. So we are grappling with all of these things. And you're a group of people who's a very high functioning, passionate group of people who under normal circumstances probably doesn't operate with a whole lot of margin to begin with because you're so hardworking. So I read through the conference agenda. I haven't had a chance to go to all of the sessions, but what I see is that there's an eye toward social determinants of health and culture and social justice in the content that you've had. And I imagine that that has selected a group of people who have decided to be participants in it. But I do want to acknowledge, right, that within academia, within our society, there is still a resistance to this marriage of social justice and health. And this is just one example of that, very widely publicized editorial by someone who's at a very prestigious institution, and he was coming at it from the medical field. And he really bemoaned the fact that curricula was talking about things like climate change, social inequity, gun violence, bias, and progressive causes only tangentially related to treating illness, and said, why have these places become a place where we talk about this social policy stuff? And as you can imagine, some people have some strong opinions about that. One of the responses was, social and health policies have always determined who gets sick and who gets care and where and how. Understanding the social drivers of health and illness is not peripheral or tangential to health. It is the key to diagnosing and meeting a patient's fundamental needs. And I would say that we could take that a step further and say it is, of course, key to understanding a population's health and our own as well. So sometimes when a term has become politicized, it's helpful to just take a step back and go over the definition. So this is one by John Rawls of social justice, which is assuring the protection of equal access to liberties, rights, and opportunities, as well as taking care of the least advantaged members of society. And for those of us who've gone into these helping professions, this probably doesn't sound all that controversial, but I welcome you to hold that idea in your head. So when we think about assuring the protection of equal access to liberties, rights, and opportunities, this gets into our social determinants of health. And we've started talking more about things like food insecurity, homelessness, adverse features of the built environment, ACEs, educational opportunities, and things like that. But what we come up against is that these things are consistently occurring in our society, and they have consistently occurred in our society under very clear lines that have been reproduced over time, and that it affects significant portions of our population. So these are things that we know have negative implications for people's health, whether it's their mental health or their physical health. And yet we have constructed a society in a way where large proportions of the population are continuously exposed to them. And when we have these discussions about the social determinants, it's often after that exposure has occurred. So not to say it's too late, but that's still not quite upstream enough if we want to have a society that's truly mentally healthier. So how is it that so many people in our society are contending with these things, particularly in a society like ours that has the resources to address them? And that is fundamentally a social justice issue. It is because of that unfair and unjust distribution of opportunity, which probably is ringing some bells from that definition that we just went over. And when we look at how that happens, the setup for that are our public policies and our social norms, and the ways that the two of those things interact to shape the structures that then determine those social determinants of mental health. And so thinking about that definition of mental health and thinking about this definition of social justice, how can every individual realize his or her own potential work productively and fruitfully, and make a contribution to her or his community in a society that fails to assure equal access to liberties, rights, and opportunities, and chooses not to care for its least advantaged members. And I would posit that it actually can't. And that these issues of social justice and social determinants, that they're the determinants of, affect our society, our society's mental well-being, our mental well-being, and our peace. I do want to also acknowledge that there are ways that we are making progress in talking about these issues and bringing them up, and getting them on the table and into programming and into education, and in some ways into legislation and even some of the more recent court outcomes that we've had. But there's a way that with progress, there will inevitably come retrenchment as a response to that progress. And so there's a way that those of you who are doing this work, who are doing it with these things in mind, may experience being challenged, neutralized, or even undermined as you are doing it. And I want to point out that this is not an indication that you're doing something wrong. It's actually a part of the process of moving society forward. So not to be surprised when that happens, but to be prepared for it and to see it as an indicator that you are, in fact, moving. So with all of those things in mind, in order to do this work sustainably, in order to move your field forward sustainably, self-care is a necessary element to this being done. Audre Lorde said, caring for myself is not self-indulgence, it is self-preservation, and that is an act of political warfare. And so there are things that in your field, right, there are implications to what you do, how you do it, how effectively you communicate it, how defensible it is, especially in this climate, that can have an impact on families, neighborhoods, on our nation, on your credibility, on the credibility of the organization that you work with, of your field. And, of course, there's always the bottom line that's going on as well. And so what you do and what you tackle as a professional in your field is heavy. And sometimes it's going to feel heavy. And it's not because you're weak, it's because it is legitimately a really significant load. And for people who are in service professions, who are thinking about the public good, sometimes the things that drive you to do that work can be the things that make it harder for you to take care of yourself, and to extend to yourself that degree of compassion that you extend to the people that you work with and for. So keeping in mind that it's a thin line between the pursuit of excellence and perfectionism, constructive criticism and demoralizing dialogue, having an internal locus of control, so believing that you can do something to make the world better and owning things that aren't within your power to own, utilization of intellect and reliance on rationalization, and reaching for goals and overextending yourself. And then, of course, we haven't even talked about home and all the things that people have had to juggle during this pandemic, all of the pressures coming from these different ways, the disruptions that people have seen in work, maybe if not in your own, perhaps in your extended family members, and you've had to take on being a help for them as well. And so I'm not going to spend a lot of time on this. And I know that we'll get some time to talk more about these things, but just would encourage you to check in. Are you at a place of compassion, satisfaction, burnout, or secondary traumatic stress? For the sake of time, I won't read those, but I would encourage you all to look at the professional quality of life scale. It's public domain, it's free, you can easily Google it, and just see where you are. Also to keep in mind the words of W. Edward Deming that said, a bad system will beat a good person every time, that it's important to understand we can only cope so much. Sometimes what you need is to be in a new environment or under a new supervisor or with a new team, or with a system that is more in line with the goals that it says it's trying to accomplish in order for you not to feel burned out or overwhelmed. So if you're someone who is listening to the talk and you are a manager or a leader, what are some ways that you can have that system be more supportive for your workers who have all of these things going on in their lives? So drawing from things that we know are protective from a mental health standpoint, these are some potential suggestions. So having employee resource groups where people can get together with other folks who they share aspects of their identity with and can find that support and validation that may be harder to find on a company or a broader level. Giving people the support and the time, protected time to attend conferences like this, where they can also find that validation, support, and get re-energized. If you have parents, of course you have parents, for the parents who are working with your group, thinking of ways to provide material supports for them. I actually ended up talking to an academic group recently. They were talking about how COVID has disproportionately impacted women because of their role in caring for children. And they were talking about having a seminar about it. And I was like, they don't need a seminar. They need you to subsidize childcare. They need you to have daycare on site. So thinking about things that are practical that will actually relieve it, not just not only giving them space to talk about it. Employee access programs and mental health coverage network adequacy of the insurers that you're working with, respecting boundaries when they're set, because in virtual world, it can be harder to respect those boundaries, but understanding that this is part of supporting your workforce and their mental well-being. And then you setting examples yourself, you going on vacation, you not answering emails at 2 o'clock in the morning, you demonstrating that you're not just saying it's okay to do these things, but showing as well. And also, as you're looking at how your company is doing, your employee satisfaction, your attention, your promotion, making sure that you have stratified data for historically excluded populations. The word that's often used is underrepresented, but there's a reason they're underrepresented. It's because of that historical exclusion. Because what can happen is that if you don't have that stratified data, you're going to miss things that are disproportionately impacting those groups and not provide the support that is needed. And so thinking about where your battery is, are you on empty? Are you charging? And going back to those things that we know are important, that's connection, validation, a sense of purpose, especially for people who are in groups that have been minoritized, having a positive racial identity. Sleep, it sounds so simple, but it's huge in terms of your brain and how it functions. Movement, I don't say exercise because some people think that's a bad word, but moving in some way, having support, and then diet as well. So for many of you, I haven't said anything new. And you already know what helps you be in a mentally healthier space. The question is, have you decided to prioritize doing those things and folding that into your life, your schedule, your cadence, the same way you fold in your work or your family obligations? And I'll end with just a little bit about critical hope. And this is something that's recently been introduced to me in full transparency, but I think that it has some benefit in terms of how we think about what we do and the place that we do it from. You know, when we think about all of these big societal issues, how they're weighing on us, how they're weighing on the populations we're trying to help, or the people that we're trying to help, it can be overwhelming. And sometimes when you bring up these issues in diverse groups, there can be this tension between being critical and saying, what can we even do with all this? And the folks who just want to be sort of hopeful, but don't acknowledge all of the things that are barriers to achieving the kind of society that we are striving and hoping for. And what you do with critical help is there's an understanding that these issues, really having a clear-eyed estimation of where our country is and how it operates is going to cause some tension, some ambiguity and discomfort, and seeing that and understanding that as part of the process. It's not naive hope or blind faith. It's not hokey hope based on a bootstraps narrative. It's not mythical based on the false narrative of equal opportunity that ignores historical and political contingencies. And it's not just hope that is deferred or that is critical without actually being paired with doing something. But to say that someone is critically hopeful means that the person is involved in a critical analysis of power relations and how they constitute one's emotional ways of being in the world, while attempting to construct imaginatively and materially a different life world. And I think that this is a really interesting place for us to think about as we do this work and as we try to do it in a sustainable way. And I will just end with saying the world needs you well. And thank you for your time this morning. And I look forward to the other speakers and to our discussion.
Thank you for that, Dr. Vinson. We appreciate the dive that you gave us into the context of the current environment, sharing about how social determinants, policies, and other factors have contributed truly to the state of mental health as we know it in our MCH workforce and beyond, and especially for the introduction of the term critical hope. As we prepare to make a deeper dive into the work that we're doing, I would like to introduce you all to Dr. Mauseth. Dr. Mauseth is a practicing clinical psychologist who sees patients at Synonymous Psychological Associates in Everett and Edmonds, Washington, teaches as a senior instructor at Seattle University, and serves as a co-lead for the behavioral health strike team for the Washington State Department of Health. She also serves in the adult mental health clinical seat on the Washington State's Disaster Medical Advisory Committee. Her work and research focus on disaster behavioral health, resilience, and recovery from trauma, as well as small and large-scale critical incident response and preparation. She has worked abroad extensively with disaster survivors and refugees and has trained first responders and healthcare workers throughout Puget Sound, the United States. Dr. Mauseth also conducts trainings with organizations and educational groups about disaster preparedness and resilience building within local communities. Thank you, and I'd like to say welcome to the main stage.
Thank you, Chemyeeka. Hi, everybody. I'm presenting today from the native land areas of the Snohomish and the Stillaguamish and the Coast Salish peoples. And I'd like to just acknowledge their past and present stewardship of that land and to thank them as well. I'm happy to be joining you today, and I'm going to be talking about a little bit about disaster behavioral health. And I really appreciate so many of the themes that Dr. Vinson mentioned, and I'm going to be sort of agreeing and sort of giving you an additional perspective on some of those exact same things. So there is a lot of overlap, and I'm hoping that you can find some relevance as well for things that give you little ideas for things to consider in your own lives. I really couldn't agree more with a lot of the things that Dr. Vinson was sharing. So I'm hoping to keep us moving in that direction, and here we go. So I'm going to start by focusing on a little bit about what's happening contextually with public health and with the work that we all do in this disaster situation. It is really important to understand that we've been studying disasters for decades now. So we have a strong understanding about how they unfold and the ways in which all of our functioning is impacted. The chart that you're looking at right now is a SAMHSA graph that is designed to represent sort of an aggregate behavioral health experience across a population in a large-scale disaster event. It's based on data from things like Hurricane Katrina and 9/11, the Fukushima nuclear meltdown in Japan, the earthquake in Haiti. It's based on regional, local, and international disasters of all kinds. So it's a fairly well-known process in terms of the phases of disaster that people experience. COVID has played itself out in a similar way, but starting at different timelines and at different times of year in 2020 for different regions in the United States. So we certainly did have our impact phase, the heroic and the honeymoon phase. And then for many areas, the disillusionment phase, the first time, was experienced in the fall and winter months of 2020, heading into 2021. The Delta variant has triggered what we refer to as a disaster cascade. And disaster cascades are really tricky because anytime you're in a large scale disaster event, your resources are taxed, right? Your mental, emotional, and physical resources are taxed. And when there's a disaster cascade, what that means is that you experience more than one impact in a relatively short amount of time. So in the time frame that it typically takes people to recover from the first impact, usually that's about 18 to 24 months if we're just allowed to sort of recover without additional events unfolding. But that is absolutely not the case for COVID because of the cascade. So we've had more than one impact. Some regions, depending on other natural disasters that are weather related, such as floods or fires, that kind of thing, have had 3 or even 4 impacts on a very, very large scale since the beginning of the pandemic. So every time that occurs, you're starting at a little bit of a lower baseline with this cycle, and it just kind of repeats itself, looks a little bit like a heartbeat, right? And it extends our recovery time. So things to consider with disaster cascades mean that, we restart the cycle at a lower baseline, like I mentioned, and oops. Can you all see my screen okay? I'm just making sure that it looks like there's a comment saying that you can't. Okay, good. I'll keep on moving. So we're working from an already sort of taxed place, and then it takes us longer to recover, like I mentioned. So a lot of people have been discussing with me why this fall in many cases feels worse or more difficult and more challenging than last fall did. And the response from a disaster lens is fairly straightforward about that. A disaster cascade is sort of why this fall and winter might feel like it's a little bit of a harder stretch in terms of what we're being asked to do and the way that our work feels. So it can be triggering for a lot of people to go through more than one thing. And another question that I get asked frequently is sort of how much resilience am I going to have to come up with here, right? So unfortunately, right, there's no merit badge for resilience. It's a process that we all can undergo together and sort of contribute to and work on very actively over time, but not by adding a whole lot more things to our plate. It's about understanding where the challenges are and organizing our resources, internal and external, in order to sort of facilitate our resilience through a very, very long-term process. I will say this too about disaster cascades, that the most common outcome for any type of disaster, including a cascading set of events, is resilience. So people tend to recover to their baseline, even if it takes us longer than we had originally anticipated. So risk factors for how someone may be functioning. Are they on a cascade pathway? Or are they on the typical recovery pathway? And how are these things playing out in the way we are functioning in our family and our occupational and our social lives? It's based on 3 levels psychologically about what's going on. The first level is just fundamental, right? It's our social experiences. It's experiences about discrimination, access to care and resources, marginalization, systemic racism, adverse childhood experiences, and things that we have learned along the way prior to the pandemic even starting. So our coping skills, our external supports, and our sort of baseline level of resilience that's built on all of those other things that we've been through. The second level of risk factor is related to what we call primary COVID impacts, so primary disaster impacts. And those impacts are specifically related to the illness itself or to the virus itself. So did you get sick? Were you hospitalized? Have you lost a loved one or a family member? Have you had direct exposure as part of your job? And a lot of folks in public health certainly have done that, whether it's contact tracing or working with public, talking to people, vaccinations, all of that kind of thing. There are certainly risks for primary COVID impacts for everybody, but potentially even more so for public health as well. And then we have, in addition to that, secondary COVID impacts. And those impacts are broadly experienced across not just the nation, but even the world now. And they affect everyone in very, very different ways, depending on privilege and resource access. So we have educational, where maybe folks were in school or attending classes and didn't have the ability to do that anymore. Financial, related to housing or employment or food insecurity. Occupational, have you been completely overwhelmed? Are you short-staffed? Are you feeling like budgets have been cut, people have left? And then the amount of work that you have been responsible for has increased significantly over time. And then also our social relationships. One of the really difficult things about this disaster is the socio-political context that has pulled families apart and has created discord and upheaval with these emotional resources that we have leaned on typically in the past, or that we would consider being sort of fundamental to our sense of well-being, may not be available to us anymore because of the nature of how our relationships have played out here. So you look at all of these risk factors and you can kind of identify where things might have been influencing your personal experience, and gives you a little bit of information about how to focus your energy and your active coping. I love the concept about the hope the Dr. Vinson was mentioning, and I'm going to come back to that in the context of resilience as well. But I really want to encourage people to just have a sense of really understanding why things have been so hard, rather than just the recognition that, of course, yes, it has been, but what are the details in terms of the influences on all of our functioning right now, which are not insignificant. So for the public health workforce specifically, there is something in disaster science called sort of the disaster bullseye, and psychological effects, including new incidents of disorders, are higher risk the closer you are to the center of the bullseye. Using 9/11 as an example, the center of the bullseye would have been pretty much everybody in New York or in Manhattan on the morning of 9/11. That's like right directly affected. People who have lost loved ones, people who have lost their housing or their employment situations. When you think about an earthquake, those are people near the literal epicenter of an earthquake, and so forth and so on. The pandemic is somewhat unique. It is classified as a natural disaster, but this bullseye model still generally applies. And I would put public health workers in general in sort of this hidden second ring. These are folks who certainly have had the potential for direct and personal impacts, all of us, right? Also sort of a unique exposure in terms of the exact role of the job. This could be because of contact tracing. This could be because of public messaging. This could be because of sort of vaccine advocacy work. This could be things that the role in public health, making folks in some ways a target for personal or professional consideration or attention that may be undesired at sometimes, because of what public health has represented in the nature of the disaster response, which is a very, very unique sort of unfolding and another layer of difficulty that many of us have gone through. So we have those three general layers, and I would put public health officials and public health workers sort of in that just off the center hidden ring of this bullseye. And it's very challenging because, again, the closer you are to the center, the more difficult that may be in terms of mental and behavioral health impacts personally. So this next slide is not meant to be a checklist necessarily, but it is pretty normal if there are a lot of things on here that you can identify with that you might have been experiencing. The ones I would like to draw attention to today, let's see, physical. We went from the quarantine 15 to the COVID-19 to the buttons on your shirt maybe starting to social distance from each other. The snacking, the stress eating, especially around the holidays and the winter, is really, really challenging for people. And there are lots of really basic neurological pieces that are going on here that inform this, right? So when we eat carbohydrates, we get a little bit of serotonin, and serotonin is something that people crave right now because it makes us feel good, right? The cognitive issues, I cannot share enough how incredibly normal it is to not know what day of the week it is, to feel distracted, to feel like you can't focus. And for adults particularly, it is pretty common right now to feel like you have either symptoms of ADHD or you are worried that you may be getting symptoms of early onset dementia. The cognitive COVID brain experience is very, very real, and it's a known entity. All of the symptoms that are listed here and the experiences are common long-term disaster response situations and experiences based on all of this data that we've been collecting on disasters for forever, but also like our basic physiological response when we've been under so much stress for such a long period of time. So the more cortisol that builds up in our system, the more that influences some of these things. Certainly, because of the nature of the pandemic, certain things have been emphasized over others, but it's not uncommon for people to experience any of these things right now. On a very, very basic neurological level, there are a few things that might be helpful to keep in mind. The limbic system is very, very active in trying to protect us and keep us safe. The brain's job in a disaster is to keep us alive and to keep us safe. So the limbic system is constantly scanning for where the next threat might come from and then activating us in order to protect us. The prefrontal cortex, which is the logical, reasoned, organized part of our brain, is not as necessary or engaged in that basic physiological response. So all of our interactions with people become slightly more challenging. The human brain right now, at almost a solid 2 years into this disaster, is more likely to perceive a neutral input as being negative, threatening, or hostile and respond accordingly. So when we get a text message or another driver cuts us off, or there's something that happens that's unexpected, our brain is more likely to respond to that thing as a potential threat and then to activate us accordingly. This has huge implications for how we get along, how we can seek support from each other, and how we communicate generally. So these are 3 issues, like psychological issues, that are well understood and known related to disaster sort of response and recovery. Burnout happens when there's an imbalance, right? There's too much going out and not enough coming in, of mental, emotional resources, all kinds of things. Compassion fatigue or secondary traumatic stress is another term that we sometimes talk about. Emotional and physical exhaustion. You just can't bring yourself to empathize with someone else's experience. And then moral injury is a term that was originally a medical term related to wartime field hospital work, but it's about intense feelings about guilt or shame or anger because you just can't do your job the way you want to. So I'm going to briefly address each of these, and then we'll move on to resilience. So in order to manage burnout, one of the most basic things that research has shown us is healthy boundaries. And I don't have to tell you all this, I'm sure, but American work culture is terrible about healthy boundaries around work time. There was a meme that went around over the summer that said something like, an out of office reply in Europe says, I'm backpacking for the summer, I'll catch you in September, right? Obviously a joke. But an out of office reply in the United States says, I'm having kidney surgery on my lunch break, but you can reach me on my cell phone. And the reason that that's a meme, and it's funny, but it's not funny, is because it represents something that's actually happening with a lot of people, which is a lack of boundaries. So we really need to be clear in establishing 3 buckets related to our work. We need our on-duty time when we're at work and focused on that. We need our on-call time, because let's be honest, everybody has that to some extent, right? When we're checking emails, but it's after hours, or maybe we're available for emergencies or something like that. And then we have our off time. And I am the last person who's going to tell you how big each of those buckets needs to be for you personally, or what times of the day or what days of the week, but there has to be 3 in order to sort of reduce the likelihood and try to recover from some of the burnout that many of us are experiencing. There's also a model that I've developed to sort of keep in mind the key attributes related to reducing burnout. So we know that positive reinforcement is one of the most effective ways to change human behavior. And when you reward yourself for a difficult job or a difficult piece of work, that's very reinforcing. There was somebody that I talked to last year around this time who kept a box of chocolates on her desk. And she said that every time she had a really hard meeting, she would eat a little chocolate. Like, if you have the kind of self-control that will allow you to just eat the one chocolate, that's great, but most people don't have that. So you got to pick the reward that works for you, right, in order to have it actually be effective. And then I was talking about the boundaries, so establishing those healthy boundaries, and then sharing your feelings, not handling this stuff alone. Other people in public health also understand the work. Other healthcare workers also understand sort of the unique challenges, and it's worth reaching out, and it's worth talking to other people to process your experience. And then the last one there is to trust your people, whomever they may be. There is a medical myth of indispensability that comes with feeling like sometimes we are the only person who can do a job or treat a patient or do a particular piece of work. And that trusting piece is an essential rest and recovery component. Moral injury is about, oh, did I skip one? Sorry, compassion fatigue. Remember I was mentioning about the limbic system being so focused on threat scanning in our brain? Well, one of the unfortunate side effects of that process is that our limbic system is not doing a good job paying attention to compassion rewards. And those are the things that we get out of our job that we love, right? The kudos, the thank yous, the congratulations, the hey, I appreciate you. So our brain isn't very tuned into that. And I really want to advocate that anyone in a leadership or a supervisory role, and even absolutely from peer to peer, go a little bit out of your way to be complimentary, to share appreciation and gratitude for people. Really understand the value of going above and beyond, because our brains aren't tuned into that really, really well right now. For moral injury, one of the best things you can try and keep in mind is that there's this old parable about starfish, and I'll just tell this story very, very quickly. But let's say an old woman is walking along on a beach, and 10,000 starfish have been washed up after a storm. Maybe this hits a little differently if you live on the Pacific coast, I don't know. But she's walking along and she's tossing one starfish at a time back into the ocean to try and save them. And a child comes up and says, why are you bothering with that? Can't you see you're never going to save them all? And she picks up the next one and she said, but it matters to this one, and tosses it back. So each of us are doing one starfish at a time. And when we get overwhelmed by the whole beach, the whole pandemic, the whole length of this thing, it can be paralyzing. And we feel like there's nothing that can be done and we get angry. But moral injury can be dealt with or managed a little bit more effectively when we do focus on the true value of the meetings, the interactions, the clients, the patients, the one customer, or the person that we're talking to, where we can focus on the process that we use that is meaningful in that engagement with that other person. So sort of working your brain around focusing on and acknowledging that good work that's being done, because it truly is, and we're all doing that. So it matters in the big picture too. There's certainly a collective experience of grief and loss. And all of us have experienced a loss of some kind in this large scale disaster. But what I want to emphasize here is that our emotional response to any bereavement right now is likely to be stronger because of our neurological sort of deficiencies around how tired we are and how exhausted things have been and how long-term this disaster cascade has gone on. So our emotional abilities to sort of process bereavement and grief is a little bit more limited, and it's likely to be stronger in response than it might typically would be. We really want to focus generally on authentically interacting with someone who's experiencing grief and not trying to make them feel better, right? Not trying to fix something or solve something, but supporting them by understanding what it is that they're going through a little bit more and asking those open-ended questions, active listening kind of a thing. So for leadership considerations, I just want to echo a lot of what Dr. Vinson was already saying. I cannot emphasize more strongly how important modeling is. What you do really, really matters. Human beings always do what they're shown. They don't do what they're told. I mean, we know that, right? People don't do what they're told. So what you can model for other people automatically starts this trickle down effect where people recognize active coping skills. They recognize good boundaries. They recognize that taking time off. They recognize prioritizing connection with people. And they see that happening because you're doing it for yourself, and then they start to do it too. So we use these sort of subconscious processes that can really influence people's behavior in a healthy way, and sort of pick up all of our collective baseline as we move forward. So structuring and prioritizing time, having good boundaries, and then really, not doing more work, right? Focusing on your own, refilling your own teapot before you help others, but also just allowing people to observe that and then copy that. And then finally, I'm going to just wrap up here by talking about resilience. These are the 4 ingredients of resilience. And I use the example of a tree because it really helps sort of coalesce all of these things. A tree has to survive the storm, just like a person has to survive a disaster. And these 4 things are the ones that get threatened when we go through a large scale disaster event, but these are also the things that help us get through. So the purpose is about resetting your goals and making sure that the goals you are setting are the right size and scope. Think about just short term, think about what you can get done, the to-do, the checklist, like Dr. Vinson was mentioning, that's a living document. And also there's data to suggest that you get a little bit of dopamine from going through a checklist and giving yourself the satisfaction of completing something that's on your list. So make sure that your goals are the right size so that you can achieve and practice success rather than that they're so big that you experience failure by not meeting them. That's very motivating to have that success. That's the fruit of the tree. The adaptability is the trunk of the tree. It sways in the wind. And that's the hardest one for people because we really don't like change. We like things to be predictable and to be known. So how do we make adaptations and adjustments for our expectations around ourselves, our children or our family members, our productivity at work? We can do what we can do, and we need to adapt our sense of other expectations. There's a lot of opportunity in this disaster, for better or worse, I guess. There's a lot of opportunity to adapt. And adaptability is a fundamental part of resilience. It's the trunk of the tree that sways in the storm. Hope is the moss that grows on the north side of the tree. If you can learn how to shift your thinking in that limbic system way from threat, where you can hide, fight, or run, right, to challenge, shifting your thinking from threat to challenge allows you to break something down and overcome it. And that allows you to be aware of realistic opportunities, right? And see the other possibilities that may exist. It's always there. Hope is not the same thing as optimism. Hope is reality-based, and optimism often isn't. Optimism can sometimes be unicorns and rainbows a little bit. But hope is, again, in this example of the tree, it's the moss that grows on the north side of the tree where it's dark and cold and the resources are scarce, but it's real. The moss likes it over there. And hope is really there too, even in really harsh conditions. And then connection is the roots of the tree. And our connection is what grounds us. Those are our people, those are our groups and our communities that give us roots and support and nutrients, right? So connection can be anything that prevents isolation. God or a higher power, or our loved ones, or pets have been a wonderful source of connection for people. So these are our 4 ingredients of resilience that we want to try and go for. I've been mentioning these neurotransmitters and the neurological things. I just want to encourage people to recognize how desperate our brains are to feel good again. And remembering that the brain's job in a disaster is to keep us alive and safe, not to keep us happy. So what we need to focus on are healthy ways of increasing some of this neurotransmitter process that we've got going on in a way, of course, that's not going to be compromising or make things worse. So think about things that make you feel comfortable and secure, or things that are fun and rewarding, but that don't have bigger consequences. We want to try and cut back on the speeding or the reckless driving, the spending money impulsively. Those things obviously have different consequences. And focusing on movement, focusing on achievement, focusing on sensory support. Anything with your 5 senses is generally going to be very, very healthy and productive neurologically, as long as it's in moderation, for sure. So key takeaways from my little section today. Active resilience building, adaptability and hope and purpose and connection, that shouldn't add more to your list, right? It's just things to keep in mind in the back. Most of us have these cognitive problems right now, the lack of ability to focus and easily distracted and all of the forgetting. Did I hit send on that email? I can't remember. Please don't beat yourself up about that. Most of us are struggling with cognitive things, and that's normal. Take time before you respond so that you're not using your limbic system to respond to other people. You're using your whole brain before you formulate a response or an interaction as much as possible, even just a few seconds. Make a list of things that work for you. Get it on your refrigerator, right? Anything that takes from 2 minutes to 5 hours, and have it available so that when you have a really bad day or a moment, you can just pick something off your list. The last thing any of us wants to do after a bad day at work is to come up with something to do. So if you already have the list going, you can just, figure out what works for you, like listening to a song, petting the dog, going for a walk, whatever is on there that makes sense for you. Resilience is the most common outcome, even in a disaster cascade, like I mentioned. And when we can practice being adaptable, it pays off in spades. Adaptability is really the singular most important element of resilience in general. And you know what? It's a process. It's not a junior woodchuck badge that you get or an accomplishment. It's a process along this long road that we are all on together. And that is it for me. We'll talk about some questions, I guess, in a little while. So thank you.
Thank you. That was amazing. Not only for the deeper dive, but also the look at infrastructure and an understanding that we truly are all creating change in the lives of a starfish. And while doing so, we have to remember that we are important as well. And it's important for us to create change for ourselves. And from the cognitive things that we're undergoing, such as trying to remember the day of the week, which I remember today was Friday because of the conference. Any other week, not sure if I would have, down to giving us practical steps on how to build resilience. It's not just about saying that I am resilient, but sometimes it's understanding how am I resilient. So in understanding how to build that resilience, it really does empower me to feel more resilient and understand what that truly means. Thank you so much again to both of our previous speakers. And now I'm going to introduce you all to Patrick Ohiomoba, who is going to tell us about what we do next. Patrick is a software and machine learning engineer and tech entrepreneur. He's currently the founder and CTO of Marvin, the first teletherapy platform focused specifically on clinicians, healthcare workers, and those who work in a healthcare environment. Patrick's interests have been at the intersection of healthcare, social equity, and computer technology as far back as his undergraduate studies, during which he earned an applied math from Harvard University. He later received his master's degree in computational sciences and engineering from the Institute of Applied Computational Sciences in the John Paulson School of Engineering and Applied Sciences at Harvard University. He has served in various technology roles, software architect, systems, and machine learning as an early employee at a number of successful technology startups, and was previously founder and CTO at Zobris, a digital health startup that offered a democratized electronic medical record and vaccination management platform. Increasingly focused on the behavioral health and digital health space, Patrick has endeavored to marry technical vision with a broader understanding of the impacts of technology in society. In his current role at Marvin, Patrick directly leads the research and technology efforts, including efforts that touch on psychological safety, algorithmic fairness, differential privacy, burnout, and equity. Thank you, Patrick, for joining us, and welcome to the stage. And we look forward to knowing how Marvin can help bring us into our next steps.
Thank you, Chemyeeka. I'm really honored to present in the presence of Dr. Vinson and Dr. Mauseth, and have a little bit of trepidation and following on to such excellent presentations. I'm presenting currently from Boston, Massachusetts, where I sit and stand on lands curated carefully and with love over the last many centuries by the Massachusetts, the Wampanoag, and the Nipmuc, among other nations. And I look forward to talking to you about what Marvin is doing and what I am doing as part of Marvin, but kind of in a broader context, what we as individuals and entities and institutions can do to kind of usher in, the next steps in kind of mental and other well-being. So I'm gonna try to present my screen now, and please tell me if you guys can see it. So in talking about what we can do to better take care of ourselves, right? And this seems like somewhat of a simple question, but it's really a broad question, and and one that's kind of a nexus for both a fraught historical past and a uncertain future. And what we do in this moment, the steps that we take in this moment to to address issues of well-being, impact us personally, but impact all of our collective future. And so it seems like a simple question, but it's a very important question. I'm going to talk about this from the context of healthcare institutions and healthcare workers, right? But as I'll talk about later, as part of Marvin, we fundamentally believe that healthcare is very personal, right? And fundamentally identity driven, and healthcare, but also mental health. And so what I talk about in the context of a specific population, but a very broad one that includes maybe 1/6 of our general population, at least 1/6 of the economy, is really generally applicable. Okay. And I'm going to talk about institutional support for well-being, broader culturally competent mental health, leveraging improved tools, and critiquing of STEM-based approaches. But before I do so, I'm going to take a moment to just give a little bit of an introduction to Marvin. And I do so for some advertising, but I also do so because whenever you as a founder, whenever you create an entity, you usually have a purpose, and our purpose is to end the one-size-fits-all approach to mental health care, especially for healthcare workers and those who work in a healthcare institution. But you also have to have an understanding of what as part of that, like what imprint that you leave on the world, right? The context that you fit in and the actions that you take are going to, hopefully have, an impact on the world. And you want that to be, fundamentally a good one, even though you often have more constraints than you initially imagine, right? And so, and part of addressing this problem, one that's really so important, I think, in kind of the current world, especially, during this pandemic that, whose ending, is one that, is difficult to imagine, much less predict. It's, so even in addressing this problem, in this particular context, it's also just there's also a sense of trying to make sure that, the steps you take, from top to bottom, are ones that reverberate with, with the values that you aspire to, including institutional equity, diversity, and other things that have been well represented within this context. And so, we are the first teletherapy platform specifically for healthcare workers, and we hope we won't be the last, and we assume that we'll be successful for. And like, as I mentioned, this is a large population, right? That includes MCH, but it includes nursing, includes doctors. So while it's a segment of mental health in general and, allows us to focus, it's also one that has, a varied number of people, and, it needs a diverse, and specific set of approaches. And so one of the nice things is that healthcare workers' well-being is very topical. One, because healthcare workers are playing such an important role in the pandemic, but also because this is as Dr. Mauseth and Dr. Vinson have touched upon, a singularly difficult time for them, right? For a variety of reasons, right? It's a singularly difficult time for us all, but healthcare workers in particular, who've historically had counterintuitively issues with mental health. You think doctors and nurses and people who live on the front lines of delivering medicine would understand the importance of well-being, but they've often had suicide rates that are among the highest, if not the highest, in terms of job, occupational roles, et cetera. And so this is happening, this has been the case since, well before the pandemic, but the pandemic has obviously exacerbated this to the extent that healthcare workers are quitting their jobs, so as this article shows, 1 in 5 healthcare workers have left their jobs since the pandemic started. There's another well-known poll that I didn't put here in this presentation that I think 1 in 3 healthcare workers are contemplating leaving their jobs, right? So this is a crisis within the field. And so, so as a result, the institutions that, the healthcare institutions, hospitals, hospital systems and other healthcare institutions have, really have brought to the, top of their, agendas and to-do lists, and the idea of healthcare worker well-being, right? And in this case, it's a microcosm of the well-being of us all, but also a particular population that happens to be pretty popular and pretty important. And so, we see that healthcare workers and healthcare institutions have a large, have kind of, adopted, major support for the well-being of their affiliates, and, their selfish reasons, but however we've arrived at this moment, it's good that the support is there. And, we've done a lot of work. We've talked to a lot of institutions. We've talked to a lot of clinicians. We've talked to a lot of, of non-clinicians and other people who work in a healthcare role. And, it's validated a fundamental assumption that we've had from the beginning, right? And that's and that is that healthcare workers, and subpopulations of healthcare workers, like all of us, require, mental health approaches that are built from the ground up or from the bottoms up specifically for them, right? So if you have a major, healthcare workers are what we call an occupational identity, right? And in like any kind of major identity, if it impacts how you see the world and impacts your and it impacts your well-being. And you can imagine that someone who spends 70-80% of their life to good or bad in a particular context, that if they're receiving care that's uninformed or ignorant of that context, would have a hard time both like connecting with that care and optimizing the outcomes of that care. So like so mental health delivery that is identity aware, right, and culturally competent is something that's we feel important generally, but also very, very important for occupational identities, and in particular healthcare workers. And and a positive, one positive thing that we're seeing is that a specific, an awareness of this from healthcare institutions, which is allowing a slight decrease in some of the stigma that is traditionally, addressed and pervaded healthcare, mental health in these occupations. And so in trying to deliver kind of culturally competent health, mental health for this population, there's, we take a variety of approaches, both simple, but also, kind of more targeted or more thoughtful, right? So, one approach is just the idea that we have therapists who are familiar with the population, right? Who are familiar with the terminology, are familiar with the experiences, they're familiar with the lived experience, the nuanced lived experience, but also, familiar with, the kinds of communications or the kinds of problems and the occupational specific trauma, right? And so, that requires, often, experienced therapists, but also requires a large amount of additional training in that, in the nuanced lived experiences for this population. But that's that's something that's non-trivial, right? But there are other things that are maybe a little bit easier, such as like just delivering, being able to deliver care at times when healthcare workers are available. Often, something as simple as like the long shifts, right? Or and the difficulties of like finding breaks during lunch, et cetera, make it difficult for someone who has that experience to get, to get treatment or to see a therapist during business hours when a lot of therapists are often available. And so having therapy available off hours or earlier in the mornings, et cetera, seems like something very simple, right? But can, reduce a major friction to access for important, something that's important to the well-being, right? And matching, and there are different types of personalities and different types of experiences within, both the, therapy delivery, but also, that resound with the patient. And it turns out that what working alliance, right, is one of the major predictors for positive clinical outcomes. And so if you can, especially in the early therapeutic in the stages of early therapeutic stages. And so if you had a highly effective therapist matching, can make the major difference both in like the connection between the person and their therapist, but also in their ultimate clinical outcomes. And throughout this conversation, I'm going to talk a lot about interventions, but I just wanted to take a moment to just call out that, like many things, what we'll talk about interventions or we talk about therapists are really just people, right? People who are doing, their own best to like help other people and improve their mental well-being. And so I just wanted to, this can be like somewhat of a dry or some of like an academic topic, but I just wanted to make sure that underlying all of this is, our personal interactions and personal experiences. So, and this is something I mentioned earlier. So like I said, like just reducing simple barriers can like really decrease the friction between someone getting the need that the help that they need, right? And so in our experience so far, we work really hard to endeavor to deliver sessions whenever people need them. And we're finding that something like 80, I think it's actually even larger now, 80% of our sessions are what would be off hours. And so, this is something very specific, right? But it also kind of calls into, it also kind of, brings into light a kind of a larger point that sometimes, a variety of different interventions are necessary to improve on this, on mental well-being. And some of those interventions can be very, very simplistic, right? And as long as we have the appropriate support for both the simplistic and the complex interventions, then we can make progress. And so, like I said, I've talked about improving mental health and mental well-being from a, systematically by kind of taking a tailored approach, and I've talked about it in the context of healthcare populations, both the institutions and the individuals, right? But we are kind of, like in an increasing number of our approaches are technical, right? And we're in essentially a technological age. And so so in the latter part of my talk, I'm going to say basically two contradicting things, and kind of navigating the complexity of that contradiction, is kind of going to is going to be very important, in terms of the success of our overall endeavor of improving, mental health and mental well-being in this particular population, right? But also also in general. And the two contradictory themes I'm going to say are basically that we want to embrace technological tools, right? For the benefit and advance that they offer us. But we also want to be very skeptical and critical of these tools, as we've seen both recently and historically, that they can be, at the very least, extensions of, systemically unequal or tools for enforcing, systemic inequity. And so, but first, we're going to look a little bit at like how we can embrace some of these tools for good, right? And Marvin, one of our values is to like really embrace the user experience. And, we think about that from the perspective of removing friction. And we do that both in the clinicians that we work with. We do that for the therapists who are, who deliver care for us. But we also consider, in kind of embracing the user experience and really thinking about the user, we basically think about the user in terms of anyone who comes in contact with us as an institution, right, or an entity. And so And so that itself, right, taking advantage of like novel user interface elements, making, like access to care easy, et cetera, we approach not just as a problem of, not just as a problem of, say, a fundamental problem, like the problem of like increasing access to therapists, right, or increasing access to mental health, but also as a technological one, right? And so one of the ways this occurs is, in this kind of, we leverage in our therapist matching algorithms, is the prediction of the correct form of therapy. So one of the interesting things about of clinical therapy is that there are many modalities of it. I think at least over 200. There's always one coming up and being and gaining in popularity, et cetera, right? And while I don't think there's real support in the literature for one modality, being significantly better for general populations than all the other modalities, right? We do believe that like using like that matching modalities to, tailoring, using modalities in the matching process, that some modalities are better tailored for some people and other modalities are better tailored for other people, and that matching the right modalities and the right therapists and the right people is an important part of like of delivering better therapy. And so this is kind of one of the ways that we leverage technology, both kind of human in the loop computing, but also machine learning and other approaches. And this allows us to do a couple things, right? We see, I haven't like shown this across strata, but we see like, in some cases, increased improvement in, scores on some of the standard assessments. But it also allows us to like augment therapy with other lower acuity interventions, including like exercises or groups, and like kind of psychological safety approaches, et cetera, to like have a more comprehensive care experience, right? And I think this is the kind of thing that you can do with a technical approach to care, where you can leverage kind of technology to like really improve the care experience, right? And so this is just like, again, another kind of array of some of the interventions that we use. And like, and like I say, I'm calling these interventions, but like at the end of the day, these interventions, you can almost think of us you can think of these interventions almost like, a traditional matchmaker, right? We're finding, whether it's by machine learning, whether it's technical, whether it's like just like really understanding who the person is and who the therapists are, we're finding the right match between therapist and individual. And this, by the way, is a problem of access, right? Because if you were left to do this yourself, as an individual, you might be looking through a whole, you might be relying on like recommendations from like from a small subset of people, right? Or, trying to like look through directories and, trying like a bunch of therapists and trying to figure out which ones like match your insurance, et cetera. And this can be a really daunting problem. And one of the real issues that we see is that, people when faced with a problem like this, if they're not able to find something, which they aren't in many cases, quickly and easily, they just give up on therapy in general, right? And so while I'm characterizing this as a technical intervention, right, it's really like a technical approach to solving a non-technical problem that are giving real people real issues today. But in that vein, right, integrating, something as technical as therapy delivery with, non-technical approaches like, meditation, right, awareness practices, breathing exercises, like literally just breathe, right, can like, support and augment and create like a better holistic experience, a well-being experience, for everybody. And so part of the technical intervention includes like the systematic, and targeted, the ability to systematically and in a targeted way incorporate other interventions that are ones that are available and kind of well-known and well-known today, but just to make them accessible and to integrate them. Right? And we embrace the technology because it can do a few things, right? As I kind of alluded to a little bit earlier about the problems with access, or like the friction or the difficulty, maybe like finding a right match for a therapist, finding one that like matches your insurance, so that finding one that's affordable, et cetera. What we see is by leveraging some of these technical interventions, in many cases, in many contexts, we can actually increase access to therapy, right? Increase the number of people within an institution who are actually just even seeing a therapist, right? And so, so some of the positives, some of the positive clinical outcomes I alluded to earlier may be from therapy approaches, but some of it may just be from the fact that more people are being guided towards a journey that where they can, where they can leverage different approaches to to really consider their mental well-being. Right. And similarly, as a result, we can see, and we have seen in a number of contexts, improvements in burnout, which is, something that both my colleagues earlier discussed, and is a major problem and one of the top of mind concerns for healthcare workers and healthcare institutions, and frankly, all of us at the moment. So I've told you why we should I've kind of alluded to some of the ways in which we can take care of ourselves, right? And some of the ways we can use technology, or systematically use technology as an intervention to do so, right? But I also want to tell you to be skeptical of technology, for a variety of reasons. And I'll introduce this by just kind of by example. And so in just putting together some notes for the conversation I wanted to have with you guys, I knew that recently Google had kind of published some innovations in AI detection, artificial intelligence based detection for skin cancers, right? And so I was like, well, what's the state of skin cancer data sets out there right now? So there happened to be an article that talked about, in the Lancet Digital Health, a journal that talked about the freely accessible data sets for images of skin conditions, right? Which and these data sets are really important because a lot of algorithms and models use them for training, right? And these algorithms and models are there and used in doctors' offices and hospitals and other treatment locales to actually, as part of the interventions to actually, detect skin cancer, right? And so what this article examined 21 of these freely available data sets. And what they found was that these data sets, which, incorporated over 100,000 images, right? Only a tiny, right? We're talking about approximately 1%, 1.5% of these images had any information about the ethnicity of the patient, of where these of the patient, or the origin of the image, right? And then only 2,000 of them, approximately, so maybe 2%, had any information about the skin color of the image, right? And so out of all of these data images with any kind of skin tone interventions, right? So out of those 2,000 images, only 11 were from patients with the darkest two categories on the Fitzpatrick scale, which is a scale used to classify skin colors, including no images from patients with an African-American, Afro-Caribbean, or South Asian background. So these are data sets that are being used to train models that are being used right now in offices, in doctors' offices and treatment centers, et cetera, to detect skin cancer. And, over 100,000 images and 0 from patients with an African, Afro-Caribbean, or South Asian background, right? And it goes without saying that these are large parts of the population, at least in the United States. So this is a monumental failure, right? This is not just like a relative failure. This is like an absolute, kind of beggars belief, in fact, right? And so I draw this to highlight that, like, the process of data, generating data sets for tools that are in use right now and in use, for major and important, both diagnostic and other purposes, there's no oversight, right, to like make sure that these data sets are representational, right? And so, so what you see is just an extension, technology being used in a way that extends and maybe exacerbates, right, issues of systemic inequality and institutional injustice that, we've unfortunately seen and experienced over these many years, right? And I say this also because there's no oversight on the actual generation of the data sets, but there's also no oversight on the use of these tools, right? And we've seen, this is just one example, we've seen many cases of, of major companies, entities, et cetera, who have, as a result, been like demonstrated, burned, or put out tools that are in use, all over our society, that have similar, or been generated from similar data sets and have, and to terrible consequences, right? So this isn't so this isn't like some kind of isolated problem, et cetera, right? And so another issue is that even when the data sets are in balance, right, the model, even when the data sets happen to be balanced, like imagine a world in which, like, through some miracle, people are actually using a representative data set, that doesn't actually mean that the model is going to be unbiased, right? So we're kind of, you've seen kind of recent years, the increased complexity of some of the models that we're using, especially in deep learning, right? Like the people might not be able to appreciate the representation of scale in the image I have on this particular slide, but we're talking about, billions, many billions of parameters, right? For some of the models that are kind of like currently in use, taking, millions and millions of training hours, et cetera, which means they can't be replicated by kind of, smaller, even like mid-size like entities. And, and so these models are being, baked in with, with just even the systemic biases that exist, in our data sets and others today, right? These models are forming the basis for other models that just fine tune these models, these state-of-the-art models like GPT-3 and Turing NLG, et cetera, right? So even if the fine tuning occurs on like an actual representational data set, the model itself will be unbiased, right? And we've seen this, right, over and over again, and that it's a major problem in algorithmic models that are in use, from everything from facial recognition to diagnostics to like to other types of detection. And that these models have disparate impact on groups that have experienced historical discrimination, right? And so I'm highlighting some ways in which, there are, algorithmic fairness is a recent field, right? In which, which in kind of hand in hand with things like, model interpretability, et cetera, are trying to at least allow us to like understand the models in a better way, make them less black box, so that we can at least understand where they're biased. And, you know, through algorithmic fairness and things like fairness through awareness, you know, maybe imperfectly, but still address the fairness concerns about models and like use them in a way that has at least less disparate harm for, you know, and less extension of systemic inequality. Right? And so we see this in our own mental health models ourselves. And one of the things that we endeavor to do is to make sure that the models, that the data sets that we use are representative, right? That we use models that we use kind of approaches that like incorporate uncertainty, so that at the very least we can understand where a model is maybe making a prediction, but is uncertain about that prediction because it's predicting on an example that it hasn't seen in the data, right? Maybe, right? So, you know, to quote a famous 90s songs, y'all act like you haven't seen a person of a certain skin color before, right? And so, yeah, and so that's one of the approaches that we take. But I think the general approach is to really be aware and I guess vigilant in the kind of models you use, the context in which you use them, right? And the kind of technology in general you use, the context in which it's used, and how technology, you know, and how that technology can exacerbate or improve, right, systemic injustice, right? So thank you.
Thank you so much, Patrick, for that amazing presentation. We truly enjoyed it. Thank you to all of our speakers and presenters for this session. It's very important when we were thinking of what it was that our community and our providers needed to hear so much at this time. And we knew that mental health needed to be a topic, not only because of the service that we're providing to our communities, but also because we ourselves need that mental health and to make ourselves a priority. And I'm so appreciative of each and every one of you and the things you shared, from understanding how we got here, the fact that a lot of what we're seeing and a lot of what we're going through is not new, but a pandemic has exacerbated it all, to understanding what moral guilt and how it is that the work that we're doing not only taps into the moral guilt of others, but especially our own moral guilt, and then leading us into understanding that there are resources even for us. So in talking about Marvin and understanding that our work schedules, our lives, we understand that when helping others, it often puts us putting ourselves on the back burner. But with something like Marvin, there are things that have been created that consider the time, the adjustments, and the other things that are going on in our lives, and allows us to prioritize our own mental health. So with that being said, we are out of time, and I want to thank everyone for joining and remind you all that in the app, if you have any questions for any of the speakers or would like to engage them in further dialogue, if you are to click the 3 dots that are in everybody's profile, you can actually see their emails or message them if you want to have a meeting or just simply know more about something that they presented today here on the main stage. So thank you once again. And now I would like to turn it over to Anna.
Good afternoon, everyone. It's actually turning to me, Jessica Hule at City Match. Unfortunately, Anna got pulled away by the governor, so she is responding to that right now. Anna Novaes is the previous board chair for the City Match Board of Directors. And we now have a new board chair, Stephanie Graves, who opened with us during the welcome. But we wanted to make sure that Anna had a moment to close out her formal time with us, but she got pulled away, just so you know. So thank you all for joining us for the 2021 City Match Leadership and MCH Epidemiology Conference. We hope you had a wonderful 2.5 days with us. If you are unable to catch any of the live sessions, so the plenary, some of our workshops and skills builders, they will be built into the platform and you will have access for 90 days. So feel free to come back, even in the new year, if you want to come back and just review some things you saw at the City Match Conference, just log in via your normal login and you'll be able to access all of those. We would like to especially thank our partners at the Maternal and Child Health Bureau and the CDC's Department of Reproductive Health. Your support allows us to continue to host amazing annual conferences for our members. And we would like to also thank our exhibitors. Thank you all for being in the space with us. We really appreciate it. Exhibitors, we hope that you will be able to join us in person for next year's annual conference. I would also like to thank the City Match Board. Thank you, thank you, thank you for all that you do to support City Match and beyond. Your support challenges us to practice what we preach with intention, and to borrow a term from Professor McGee, loving kindness. I would also like to personally thank each and every member of the City Match staff. If you don't know, we are a strong and mighty team of just 15 folks. So this whole conference, everything you've seen has been coordinated and implemented by our staff of 15 people. Each member of our team has contributed to making this year and every year of conference a success. I would like to also shout out our 2021 student interns. They've actually played a major role this year. They planned webinars, moderated a couple sessions, and also contributed to the planning of our community service event. Speaking of which, if you have not had the opportunity, please check out our service event, Give Back to the Big Easy. Though we are not able to be in New Orleans at this time, we want to make a significant impact. Therefore, we're highlighting 5 organizations doing great work in the New Orleans community. We encourage all of you to join us in elevating the great work of these organizations through social media and other communications methods. We most importantly would encourage you to donate. So if you go to the homepage, there's a virtual exhibit booth where you can click on, it says Give Back to the Big Easy. You can click on each of the organizations and go there for instructions on how to donate. Please do visit that if you haven't had a chance to. And like we said, you'll have access to this platform for 90 days post-conference. Following this event, you all will receive an email in your inbox about evaluation. Please complete this conference evaluation, and your feedback is very invaluable to us. We use this to change and transform our conference each year. We actually read each and every comment as well, so please do complete those evaluations. We are excited to announce that in 2022, our conference will be in Chicago, Illinois on September 21st through 23rd, 2022. So mark your calendars, get ready to be in person, bring your dancing shoes for a Friends of City Match that's actually in person. Our theme for next year will be Onwards and Upwards, Accountability for the Past and Building Toward the Future of MCH. To close out our virtual event today, I would like to introduce Crystal Cooper Taylor and Dwayne Taylor Jr. Crystal Cooper Taylor is a graduate of Bossier Parish Community College and Louisiana Baptist University with a degree in communications. She is a community mentor that partners with Family Resources for Education and Empowerment and City Match through the local health department to improve healthy birth outcomes. Crystal is a Healthy Birth Ambassador for Region 7 in the state of Louisiana. She is also the co-founder of Taking Care of Mama Doula Collective, a certified lactation specialist, childbirth educator, doula, midwife assistant, and student midwife. Outside of birth work, Crystal partners alongside her husband, Dwayne Taylor Jr., to serve through music. Both were raised in households filled with music influence and talent. Please check out their music available on all digital platforms. Crystal and Dwayne reside in Bossier City, Louisiana, with their 2 beautiful children, Dwayne and Lillian Taylor. You can also find them on social media. You can find Crystal at CCTMUSIQ and School Mom Chronicles. You can also find them on YouTube just by typing in Dwayne and Crystal Taylor, and also on Facebook. Thank you once again for attending conference. We look forward to seeing you in 2022 in Chicago. And please enjoy this closing performance by Crystal and Dwayne Taylor. Thank you.
Hey, I want to tell City Match, thank you so much for having me today. And I want to leave you. It's gonna happen. Woo! Hey. I was sitting here to tell you today that troubles don't last always, and whatever you face escape. Listen to the voice in your head, whispering the path that's ahead. Just keep on believing and don't stop dreaming. 'Cause I believe that change, yes we can change. Change, yes we can change. Hey, yes it takes courage, yes it takes faith, but with God's helping hand, nothing's impossible. So get up now, so stand up now. Say change will happen, and change will make things new. Yeah, yeah. Change, hey. Change. Yes, we can change. I believe that change. Yes, we can change. Oh, I believe, yeah. I believe, yes I do, yeah, yeah. Change for my brother, change for my sister, change around the world, change around the world. I'm gonna see change for my brother, and change for my sister, change around the world, change around the world, change for my brother, oh, change for my sister, change around the world, change around the world, change for my city, change for my community, change around the world, change around the world, change, I believe, yeah, change, I believe, yeah, yes we can, together we can change, oh, change, yes we can change. Hey, now what I want you to do is I want you to begin to call out your city. Woo! I live in Bossier City. I believe change is gonna happen. Change in Shreveport. Woo! Change in your region. Oh, I believe, yeah, your labor is not in vain. You will see the change for your city, for the mothers, for the fathers, for the children. Oh, I believe change, yeah, change. Yes, we can. Yes, we can change. Together we sing change. Come on, sing it out loud. Hey, change. Together, yes, we can. Yes, we can change. Now, before we end, I want to give you a moment just to celebrate right there. Hey, come on. See the change. Be the change. I see it. 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 a smile on your face. Oh, rejoice for the change. Rejoice for the change. Remember that your labor is not in vain. You will live to see it. You will live to see it. Oh, together we stand and we speak change. We do the work. We do the work. Oh, one more time together. Can we sing change? Come on, say change. Woo. Change together. Yes, we can. Yes, we can. We can change. Thank you.